Good morning, y'all. I'm Phillip Woodworth, general surgeon, fancy plumber. I don't know anything about investing, but I know good ideas when I see them. So I work at the Institute of Esophageal and Reflux Surgery in Denver, Colorado. I'm a minimally invasive robotic surgery, and we work out of Sky Ridge Medical Center in the robot department they've developed for us there. We focus as a partnership on the treatment of foregut disease, reflux disease. Truly, we do research, we do company evaluations, product development, and care for patients every single day. And we even have a therapy dog if you stop by and see Sienna. So we're not really just a local practice. We are truly an international. I refer to us as a quaternary practice. So even when the University of Colorado has patients that they can't figure out, they call us to treat the patients and take care of them. So I like to have objectives during the talk, so I'm not just up here telling stories, but I hope at the end of my little spiel here, you understand a little bit about reflux disease, esophageal cancer. You understand the issues with the development of the disease and identifying it and subsequent treatments, as well as identify opportunities to improve the algorithm that we're currently using and to know the value that Esophageal does provide to our patients. Okay, so what is reflux disease, or GERD? Well, it's a foregut disease. And foregut disease exists from the element of the mouth down through the esophagus to the second portion of the small intestine. And the most common disease affecting the foregut is gastroesophageal reflux disease, or GERD. And GERD is a digestive disorder where stomach acids inappropriately elevate out of the stomach and move up into the esophagus or higher. All right? Key to understanding this is that everybody has a little bit of natural reflux. So it only becomes a disease when this reflux becomes impactful on your daily life. It begins to impact it in a negative way. All right, does anybody in the audience have reflux? Anybody want to share? Yeah, okay. Yeah, it sucks pretty bad. I'll tell you a story later, but classic symptoms: heartburn, regurgitation or food coming up. Problem swallowing as the reflux gets worse, the esophagus gets raw, starts to peristalse inappropriately. People will just say, maybe I don't have heartburn, but I kind of feel queasy or indigestion. And chest pain drives a lot of people to the emergency room, especially as you get older into the cardiac concern years. A lot of patients will show up in the emergency room with complaints of, oh, I think I'm having a heart attack. No, it's just bad acid reflux, too much chili. Worrisome symptoms are unexpected weight loss, blood actually in your saliva, or severe problem swallowing food where it's getting stuck and not going down. These are times that we start to think about the presence of esophageal cancer. The unfortunate aspect of this is that this is usually a late sign. It means the cancer's progressed, and I'll tell you a little bit more about why that's a problem. So again, a quick anatomy lesson. The esophagus, the foregut, comes from the mouth down to the second portion of the small intestine. A blow-up section. Here's the lower esophageal sphincter where the esophagus and the stomach meet, and there's another sphincter at the other end, but this is where we're going to focus on talking about for reflux disease. So basically there are two key elements. There's a couple of things, but the two key elements that have to do with forming this barrier are, number one, the lower esophageal sphincter, a muscle area at the bottom of your esophagus, and a diaphragmatic pinch, a pinch where the esophagus is augmented. The LES mechanism is augmented by the esophageal pinch. Anybody ever heard grandma has a hiatal hernia or anything like that? We're talking about a loss of the pinch in those kinds of situations. All right. So reflux is a valve disease. It's an anatomic problem. It's not a chemical imbalance. It's not an emotional state. It's a failure of a mechanical system. So it's important to remember that. So when the LES valve works, food and liquids will come down in the stomach and stay in the stomach so that when you swallow, things will come down, the valve mechanism here will close, and what is supposed to stay in the stomach stays in the stomach. When you have a reflux disease, the valve has failed, allowing gastric contents to reflux back into the esophagus, and that's where you'll develop those symptoms that I mentioned earlier, the heartburn, the indigestion, the chest pain. You can see the effervescence of the acid. Okay. So again, normal, reflux on the left here, or the right, excuse me. So where is reflux disease? Where do we find it and encounter it? We've already seen in this room, it's prevalent probably in 40% of you all. But I'm going to tell you it's everywhere, okay? And I didn't have to go to a lecture or do any special epidemiologic studies. like they did here out of Barcelona, where they said, hey, this formal study, 18 to 30% of Americans suffer from reflux disease. I didn't need that, because my prior job before coming to Denver was in Northwest Arkansas, Bentonville. And does anybody know what's in Bentonville? World headquarters of Walmart. And so you don't have to go to business school to understand business when you live in Northwest Arkansas. You just have to either fish, hunt, or play golf, because everybody there knows what they're doing. Because Walmart, I'll tell you, doesn't do anything without carefully considering what it's up to. So if you go into one of the stores, you'll find milk at the very back. It's so that they force you to walk through their store to get the milk where they sell under price, and then you fill up your cart on the way back. But as you approach the cash register, their profit margin increases exponentially as you get closer and closer. And when I know that they've placed everything in their stores to maximize profits, I know that there's a good market when you bump into this guy at the checkout line. Larry the Cable Guy, he's at every single Walmart checkout line, because when you've got those pork rinds and those Cheetos, you're gonna need something for a little bit later. So that's your market analysis there. Okay, so what do we do to manage reflux disease that I told you is everywhere? Well, we're not. We're really not, honestly. I mean, I'm a physician, I take pride in my work, but I can tell you we're failing at this as a medical community. So we do have algorithms, we have a plan. It's all written down, just there's the plan. The problem is it's complicated. You gotta go here, you gotta go there, you gotta see different specialists. It's really difficult to navigate, so it's not an ideal, there's no Farfignugan in it. There's no joy in progressing through it. Most of the patients direct care themselves. They show up at a pharmacy, they walk down the aisle, they pick one of their favorite flavors of antacids or medications, and they treat themselves. Lots of different options here. Even the formerly prescriptive proton pump inhibitors are now available over the counter. They're stronger, they're better, more effective than Tums, but people still walk around with Tums in their pockets. That once a year visit to your family physician, they're really concerned talking to you about your weight. They're worried about your blood pressure. They're worried about your diabetes. So when you say, I've got a little bit of heartburn, they're like, lifestyle modifications. Don't drink alcohol, no caffeine, no chocolate, don't eat late, sleep sitting up, lose weight, and always quit smoking. I mean, there's no fun in that, especially as we approach the holiday season. Or they try to refer you to a gastroenterologist, and that's really, really hard. I don't know if you've ever tried to get an appointment to a dermatologist or a gastroenterologist. It's like, I'll get to Mars before I get there. So that's complicated. So what do they end up doing? They write a prescription. That's easy, all right? They failed the lifestyle modification, so they'll just write a prescription. That'll get done, and they'll go out there and they'll pick it up. And they're writing a lot of prescriptions, I'm telling you. Yeah, billions of dollars are spent every year trying to manage this disease without ever really evaluating it. So we're not really fixing anything. We're really just doing better living through chemistry. As I said, reflux disease is a valve problem, and all we're doing is we're masking it. There's a hole in the bucket, and we've changed the color of the water leaking out of the bucket. That's all we're doing presently. So, again, medications don't stop the reflux. It's a valve problem. Even though there's just ash coming out of the volcano, it's not lava, it's still erupting. So think about it that way. The regurgitation of gastric contents are continuing. And mind you, that we've altered the chemistry of what we're refluxing. Our bodies weren't supposed to be exposed to altered chemical states that are coming from the stomach. So we're modifying those. American Gastrointestinal Association said, half of the patients are getting no relief from the medications or the treatment plans that they're doing, and their own data says almost half of them are unhappy with their current treatments. So there's a real sense of expectation. There's an unmet need out there in terms of treating this. There's an opportunity, as I would like to see it, to really intervene and take care of patients. Remember, medications, no matter what we're doing now, does not stop the progression to esophageal cancer. I've told you, we're not fixing the valve, we're only changing the color of the refluxate. We're going from lava to ash. So, we start off with just symptoms. We progress to low-grade changes of Barrett's esophagus, as we heard about in the previous speaker's comments. Those changes become more threatening until we end up in esophageal cancer. So that's the progression to cancer. Start off from symptoms all the way to cancer. The progression of cancer starts off small, and then just like any other cancer, as it grows, it invades deeper and deeper through the layers of the tissue. What makes the esophagus unique and very troublesome is the fact that it lacks a protective lining or exterior coating called a serosa. So the cancer does not meet a natural barrier like it would in the colon, for example, where it hits an edge and has to figure out how to navigate this. It can just walk straight on through, and that's why we see the rapid progression of this disease if we don't catch it early. You're going to see this slide all over again. This is true. We are just failing at treating cancer. 1970s started increasing. It was kind of floating around, something happened, and it changed. So cancer deaths, I just updated this last week. 5-year survival is around 22% out of all those patients identified with cancer. 5-year survival, you're probably going to die if you get this disease. Compare that to breast. Look at this, 91% survival rate. We're doing really, really, really well with breast. So winning the battle against cancer is not impossible. We just must be doing something wrong. So the increase in esophageal cancer seems to parallel the introduction of medications. And some people think that the medications may be at play. That we don't have any direct evidence, but it seems awfully strange that once we start playing with the chemistry of the stomach, esophageal cancer, distal esophageal cancer rates suddenly went up. I tell my daughter all the time, life's a bookshelf. If you put one thing on the one end of the bookshelf, you've got to ask yourself what's falling off the other side. So I worry about this. And again, the medications that we're using to treat this are not fixing the actual problem. We're just masking the problem. All right. We're not doing the screening we need to. And you're going to see numbers all over the place. But the key thing here is that if we've got this many patients, 46 million patients that we're identifying as potentially needing some sort of screening, and we start following the guidelines, we're still only screening a fraction of that, less than 1 million. Again, there are too few gastroenterologists, there's too few opportunities to do screening, so this isn't working. And this has been our mantra. We've been trying to do this for decades. So remember, this is our mechanism of handling esophageal cancer, detecting it, and those rates just keep going up. So we're failing. In fact, Jeff Peters, Cleveland Clinic, I love this. That's why I quoted it. Our current approach to the prevention and management of gastroesophageal reflux disease, and therefore cancer, is an abstract failure. We are failing at this disease unlike anything else. So quick story. All right, I call this EsoCheck and the Heartburn Chef. So everybody's busy nowadays and has a busy job, and there's this young entrepreneurial chef in Denver. He's in his 40s. He's starting up his second restaurant. Lifelong reflux disease, horrible, to the point now where he's walking around popping Tums, and he can't really taste the food he's preparing. A friend of his says, hey, there's this Lucid testing center. Why don't you go get checked? And he says, I don't have time to take off a day to go get checked for this. I've got all these other things I've got to do during the day. I can't take off one day for my business. And I said, no, you can pop in, get the test done, and you'll go back to work. No anesthesia, anything. So he does it. Lo and behold, the test comes out positive for DNA methylation, suggesting that he has Barrett's esophagus, a precancerous lesion. Gets an upper endoscopy. Oh yeah, he's got precancerous changes in his distal esophagus. So he gets referred to me. I do an operation for him, turn off his reflux. He puts away the Tums. He's back at work. He's more productive, sleeping better, now opening his third restaurant down the street from our hospital. I'm hoping to get some French fries for free. Yes?
How common is it that the observable symptoms of pre-diet cancer are then treatable after having diagnosed it with the EsoGuard? As in, how often do the symptoms belay that it's too late to treat it?
So how often do the reflux symptoms mean that it's too late to treat the reflux disease? So it's never too late to really treat the reflux disease. At least as a surgeon, I always think, so the cancer. So from the late, that's difficult to say. I don't think you can directly quantify a symptom to a survival rate. It's going to be directly based on the pathologic findings. The depth of invasion is a more accurate way. The canary in the coal mine can't tell you how many passages are flooded with carbon monoxide gas. So if the canary dies, you don't know the extent of it. Does that make sense? I'm trying to come up with an example. I don't have a great answer for you on that.
Maybe this one, please.
Okay.
Yeah, so you said you turned off the DNA methylation, so you had Barrett's esophagus, pre-malignant lesions. How did you turn that off, and did you fix his esophageal sphincter so that he no longer has sphincter?
Yes. Okay. So we don't turn off the methylation. So the question is, did we turn off methylation or repair the methylation by fixing the sphincter? The answer is the methylation is not something that we directly as surgeons fix, but do know that our cells are constantly modifying. They're being surveyed and correct. So methylation is a variable state. It's like the weather. It'll be hot one day and cold one day. So now if I turn off the stimuli for methylation of the DNA with reflux surgery, then yes, I can provide an opportunity for even regression in certain patients of their precancer state. And I'll show you a procedure that has been shown to have regression. So a little bit off topic though, is what I find exciting about this is if I have an opportunity to identify somebody at an early stage in their reflux disease and intervene at that early moment, then my ability to not only stop their reflux disease, but offer them an opportunity to preserve esophageal function, meaning long-standing reflux disease can lead to dysfunction, trouble swallowing, so I can preserve that, and offer them an opportunity in certain patients with short segment Barrett's to actually regress them back to normal tissue. So prevent cancer, reverse their risk factors for cancer. Okay. Anything else? All right. He's happy. I'm hoping to get something out of it. All right, so what about the future? Okay, so I already told you that the patients are everywhere. We don't really have to look at them. This is just the beach out of the Jersey Shore. Study that came out last month says that our current problem with reflux disease and cancer is not only going to continue to increase in the United States, but worldwide. The projections in China and India alone are profound. So this is not a market that's going away. It's getting bigger. We've got new drugs coming, and we're beginning just to hit the US market. So there's going to be new treatment algorithms. There's going to be new ideas about how we manage this. And so there's going to be a new interest. You're going to see advertisements on TV, so as public interest and education grows, people are going to be saying, hey, what else can I do about my reflux disease? Sleeve gastrectomies, 150,000 done last year in the United States, about 500,000 done worldwide. When I remove this section of the stomach, I make the pressure in this area, since it's a smaller volume, higher. And increased pressure in the stomach here causes increased reflux. So I'm anticipating in the next decade to suddenly see a spike in esophageal cancer related to sleeve gastrectomy. It's coming. It's coming for sure. This showed up at my door. I'm over 50, so I get AARP delivered to my house now, and this was literally in the thing that came last week. I took a picture of it. But the awareness about reflux disease is increasing among people. The longer that we're living increases the opportunity to develop this disease process again. So again, I'm looking for a way to intervene early. So progression to cancer, again, starting off with symptoms, moving through changes to cancer. Our window of opportunity is to find patients that currently aren't getting endoscopies and screen them here so that we can intervene and prevent cancer. If we prevent the progression to cancer, we've initiated a cure without performing surgery for the cancer itself. EsoCheck is a great thing. It's very simple and easy to do. It's easy for physicians to refer patients for the EsoCheck. Now they can, it's just like writing a prescription, they can write a referral to this, they can do it in their office, they can go to a Lucid testing center, or they can go to a van that pulls up at a fair and treats firemen at their annual ball. This is the Lucid testing center in Lone Tree, Colorado. You walk in, there's a nurse practitioner, they provide you a very thorough evaluation and then perform the test, and then you can go out and have lunch. Pretty nice. At our Heartburn Institute, we've instituted the call to our center. We take a history, we get an x-ray of them, and we send them to Lucid. That is our model. We want to know. Our goal is to identify DNA methylation. So once we identify that, we've got a positive test. Patient now knows, now they're engaged. We can collect these patients, and then we can hold on to them. We enroll them into our Heartburn Treatment Center, evaluate them fully, And then more importantly, we continue to follow them. So now they're engaged in our healthcare system and attached to the hospital. Diagnostic endoscopy, no longer a screening endoscopy. Now we're doing Medicare, Medicaid, private insurance, private payer funded diagnostic screening. Well focused. And again, if we identify these patients early and before they develop cancer, we can avoid using the knife to operate on them. Hospitals like this, heartburn is an easy business for them to get into. It's not a lot of overhead, but it drives a lot of revenue because it brings cases to the hospital, it activates their pathology department, engages their endoscopy department, as well as radiology and other services. ER now has a place to offload those patients with atypical chest pain. This is a very low-cost, easy entry, prevalent disease process for healthcare systems to enter. And it makes me happier because identifying patients and engaging them gets them closer to me being operating on them. Currently, we're operating on just 0.1% of the population that has reflux disease. Probably in the realm of 10 to 20% of those patients actually need an operation. Not everybody needs it, but we're not doing it. This is the Lynx device. This has been the device that is associated clearly with regression of early Barrett's when used. Okay. Remember, surgery stops reflux. We've reestablished that barrier. This is Beaver Lake in Arkansas. All right, let me wrap this up. So what do we want? We want a parade. I'm serious. We're in New York. You guys got the Valley of Heroes outside, or the Canyon of Heroes out there, ticker tape parades. We want to have a parade. Because when we celebrate, we recognize that we've had success, and we gather. In Coney Island in Brooklyn, this October, tens of thousands of women showed up to march in their support for breast cancer. 4 million women are living today in the United States as breast cancer survivors. The American Cancer Society says since 1989, when they began aggressive screening, they've reduced the mortality from breast cancer by 49%. We don't have any marches. Coney Island is empty. Esophageal cancer, you get it, you're going to die. It's one of the big three. So I would like to see us get to the point where we're back a few years from now talking about the parade we're having in Coney Island, just like the breast cancer one. And I think Lucid is leading the way in getting us there because they're providing us hope. Thank you.